So tonight is hospice care, palliative medicine, and we're so glad to have Dr. Mike Zepeda here. He's going to talk more about his family and where he came from, and he's at John Peter Smith Hospital. But we're so glad to have him here today. We're glad to have you here today. And so can you just welcome Dr. Mike? Here he is.
Is that on? Oh, now it's on. Wow. Echoey. All right. Well, I'm Dr. Zepeda. So I work at John Peter Smith Hospital. I graduated from Tufts School of Medicine, and that's out in Boston. And then I went and did my residency in Ventura, California, and then came and moved here in Texas in 2010. And I've been at JPS since. So I started out actually as a hospital doctor, so kind of when people come into the emergency room and then they need to stay, then I'm the doctor who would take care of them when they would stay on the floor. And maybe about, I should know this because it's exactly my second birthday, so about 8 years ago I started palliative, and so I started working as a palliative physician up there. Too echoey?
That's forward, that's back.
Oh, forward and back, thanks again. Testing, all right, there we go. So, yeah, 8 years ago, I actually started as a palliative doc there. So I was working as a hospitalist, and there was a lot of nights. So I was doing a lot of like 1 week stretches of just night and away from my family. And so I had one of my friends come and ask me to see if I could help out on the palliative floor instead. And I had been working with the cancer doctors as one of the hospital docs as well. And they said that they enjoyed maybe my interactions with patients and kind of, especially around very difficult times. And so they said that they would train me up. And so I've been doing that now for 8 years. And I started working with Serenity Hospice around that time, which is a Spanish-speaking hospice down in Fort Worth. And let me see, what else about me? So I have a master's in gerontology, which is the study of aging, right? Aging studies. It seems like actually your seminars were almost exactly what I spent a good 2 years doing. And I actually was a representative for our regional advisory committee for the area of agency on aging. So Parker County has its own, right? Each county has their own, and I was the one who represented Parker County, although I haven't actually been up to Springtown. So I was down in Weatherford most of the time at our senior center, and so I would kind of talk there. So a little bit about my family. Maybe I was asked to say that too. So I'm married. My wife, Julia, is she's also a family doc like me, but she does post-hospital discharge and kind of this Health Connect clinic, which is when people leave our emergency room and they've not been connected at all into JPS system, or they don't have a primary doctor, which is very common at JPS, then she gets to be the first face that they see on their way into our system. And takes care of maybe more complicated patients that haven't really ever seen a doc, or maybe are in between systems. We have 3 kiddos. So I've got my oldest, Sebastian, is 11, and he is, I guess, in 6th grade right now. And then I have my middle, Athen, is 8 years old, and so I've got first 2 are boys. And then my youngest, Emily, is actually 5. She's our beautiful adopted daughter from Hungary. So the Lord sent us out there. We lived there for a summer, answered some prayers essentially, and brought her home. She's my special little girl. So she's got a little walker. She's actually blind, but she's a cute little blessing for our family that we did. So that's about me, I think. So I'm supposed to talk about palliative care and then hospice, right? And they're not entirely the same thing. So I think maybe people kind of have a good handle on what hospice is, but palliative care is something that maybe happens before hospice, kind of includes hospice. It's a bigger umbrella. And essentially what that is anytime somebody has some sort of disease that won't go away. So it doesn't always have to be, I guess, immediately terminal or like they're going to die from it soon, but it might be something that they've had for a long time, and it's generally something that's some kind of end stage disease. So that can be lots of different things. So for us, normally what that is people would qualify for palliative care or to meet palliative care teams if they have COPD, so sometimes that's just difficulty breathing and kind of lung disease, or if they have congestive heart failure, which is just where their heart isn't beating completely normal anymore, it's a little bit weaker. If they have the beginnings of liver failure, so like cirrhosis, then that's another reason that our team would meet them. People who have end-stage renal disease, so that means that they are on dialysis, they would be allowed to meet us as palliative providers, but they don't necessarily have to make any decisions, but it's just for us to kind of come and spend time with them. And then probably the biggest reason that people come and meet a palliative care team is because they've been diagnosed with a cancer. And normally that's cancer that is either a stage 3 or a stage 4. So there are 4 stages of cancer, right? The first one is where it's very small and it hasn't moved anywhere. The second, it started to grow. The third, it started to move to different lymph nodes, which is where infection or cancer drains. And then the fourth one is where it's moved and it's moved someplace far, so it's distant. And so people who have stage 3 or stage 4 cancers can meet the palliative team. And so what palliative care docs and teams do is that they're actually an interdisciplinary team. So I normally come with a lot of people when I come to meet people for the first time. So I'll be there, and then I normally will bring a chaplain because we recognize that there is, especially in the time where we start to talk about end of life or even just future, that of course spirituality and kind of your relationship with God is incredibly important, and I think that's where there's a lot of questions that already start, and those are not always medical questions, so I have a chaplain that generally comes with me. And then I have a social worker who kind of helps out with emotional support and things like medical power of attorneys and kind of, thank you, sharing kind of where you would go to get trusts or wills or all those other things that it sounds like y'all learned about in the last couple seminars. And then sometimes we actually have nurses that come with us as well. And so when people meet me in a hospital, I would say it's normally because they've been diagnosed with one of those things. So maybe, well, I guess most frequently it's cancer, but maybe they've come in and they've had multiple hospitalizations for their lung disease or for their kidney disease or their liver disease or any other number of diseases that we know are serious and won't go away. And then we get to come and meet and talk to them and spend some time. And what palliative care, I think, does is that we try to spend time with people to find out kind of what they really value and what they really want, and then try to direct care towards that. So maybe as an example, I would say that sometimes in the medical system, people will come in and they may be diagnosed with something and the doctors have a plan, right? And that plan doesn't necessarily have to go and align with what the patient's plan is, right? What your plan might be. And so, for instance, I would say, sometimes I'll meet somebody where they say, okay, you know, they've been diagnosed with a cancer and they've been told this is when the chemo days are. And when they feel like they want to relay to their physician, you know, I really want to make it to the graduation that Thursday, right? And my chemo's on Thursday. And is there any way that we can adjust this? Then I guess I would say that sometimes the oncology or the physicians don't always hear those things, right? They kind of say, this is the plan, it's been put in place, and then people just kind of get going. And so what the palliative teams do is I would say that we are advocates for people. And so we'll sit there and we'll hear out all of that. We'll be like, they actually said that, their grandson is going to be graduating that day. And so we really need to see if we could switch this stuff around, right? And I think it's, maybe it's a little bit easier because it's normally like a physician talking to a physician. And so then I tell the cancer doctors, these are some of the things that they value, and this is some of the stuff that we need to kind of work around. And then we figure that out together, and then normally come back to the patients and kind of coordinate that. So some of that, I guess, is also not just kind of values, but it's goals of care for people, so kind of what they're really looking for. So I think that commonly, physicians think that the one thing that people want is that they just want a cure, right? And that can be a very difficult thing, I would say, with palliative medicine, because not everything has a cure. And so when we have diseases that can't be cured, or at least not cured medically, maybe cured because God can cure them, right? But not medically. No. Then that's something that we help with. So we kind of say, okay, well, if we can't cure, then what are our other potential goals, right? And so the common ones are people just want to live longer, or they want to make it to something. Like, I was really hoping to make it to Christmas this year. And so let's see how we can do that, right? Or I enjoyed the way that my life was right before this disease happened, and I kind of want to be just as mobile as I used to be, right? And I'm hoping to go back home and kind of get back to that mobility and kind of get back to spending some time with my family. Or finally, I would say that some people just tell us that they just would prefer to be comfortable, like they don't actually want to even deal with something that's like a terminal disease, but instead they would want to focus on just spending time with their family, and they say, okay, well, if I have this disease and I'm only supposed to have this amount of time, then this is what I want to focus on. So those are things that we kind of help steer people towards and help them with. And then I would say finally, as a palliative doc, one of the things that I'm asked to do, which I feel like maybe docs don't always do, is that to the degree that I can medically, right, I am supposed to talk about prognosis, and so how long somebody actually has, so that people can really plan, right? So there are some diseases where I may say, this is years, right? Maybe you've got started on this, well, you've got 5 years that, we shouldn't even really be talking about stuff, but that still allows people, I think, to be able to plan and kind of make some plans. And then there's other diseases where maybe I'm sent in and I'll sit down with people and I'll say, based on our medical studies, this is a disease that you only have about a month left, right? And it doesn't mean that I'm right, because those are just all that's just medical guesses. But I would say that that is something that at least lets people kind of really think about it, right? And so some of that I think is a little bit intense, but I will say that most of the time people actually do have that question. They really do want to know from the doctors. And maybe even myself as a hospitalist before, I would say that most physicians don't want to answer that question, right? We kind of want to walk around that. We would prefer not to give an answer to people, because I think all of us also have hope, and it's really tough to tell somebody, well, you only have maybe 3 more months. So if you're shooting for graduation in 6, then maybe we'll have to figure something out, right? Maybe my social worker will have to sit down and see if your grandson can graduate early in their own little ceremony, which is stuff that we've done. Or maybe, if you were planning on getting married, then you should really consider that earlier, and my chaplain will help out, right? So different things like that, but those are things that we've done. So that is kind of palliative care, but it's a big umbrella, and so I will say one of the nice things about palliative care, though, too, is that I do have people who do get better, right? Or don't see us for a while, or sometimes they have a very long established relationship in clinic where they meet us in the hospital, and then they'll see us for the next couple of years before they really have to maybe answer some big questions in life. But they kind of just get an intro to us. Palliative care actually is now a little bit more common in our communities too, and so a lot of the hospices are doing palliative care, and they're doing it earlier, and so they're like willing to go and meet people, spend time with them in their house, and actually kind of get a good snapshot of who they are as a person, and then try to advocate for them when they finally get to a hospital. So let's see. So hospice care is different, right? So rather than the huge umbrella, it's similar diseases, but I would say that I normally, when people go on hospice, you have to have a palliative physician or a physician qualify somebody and say that they think that that is the last 6 months of someone's life. And so it's the same diseases, but the difference is that normally people are maybe a little bit weaker at that point in time, and maybe they know, or they already feel sicker, or they've been going through chemotherapy and it hasn't been working well. And then what a hospice team does is that they can meet families, and then rather than focusing on care for treatment and cure, it's care for whatever the other goals might have been, right? So if it's care, it might be care for living a little bit longer or making it to a certain thing, or it can be care for just making sure that people are more functional. So sometimes that can be like, I need to get to a baseball game and the oxygen tank isn't really working well, so how do I make it there with a portable oxygen tank or something little like that, right? Or it can be, I'm not as functional anymore because I have pain from this disease, and so then we kind of help out with pain. Hospice care can be the whole 6 months, though, and you're allowed to continue it, right? So I think maybe one of the hospice diagnoses that's a little bit different from other ones is something like dementia, which I feel like you all talked about Alzheimer's last time. But that one, if somebody is a little bit less functional, then they can join hospice care, and then somebody would say, okay, they no longer have to drive to the doctor, or people don't have to take them to a physician, but instead the physician comes to them like a home health service. But the difference is that it can keep going. So as long as they still have dementia, then people are allowed to kind of keep renewing. So maybe a good example is I had a sweet lady who joined on hospice, and that was because she had dementia and she wasn't really able to get outside of her home really well. And even though it said last 6 months of life, that isn't always true, right? It can also be people who just needed more assistance. So a couple years into her actually being on our service, then she kind of needed other things, right? But instead, in the beginning, we would just come over, we'd visit with her, we'd spend time with her, we would help out with little things. So one of the examples is that when you're in the medical system, like the standard one that I think everybody thinks about, where you go to the doctor and then you're in the clinic and then you ask for certain things, you have to go through all of the insurance paperwork, which I'm sure that some of you have experienced, which is not all that fun. Where maybe you say, okay, well, I need a walker, or I need this medical equipment, or I need oxygen. And there are different rules that something like Medicare has for that. And so they will say, okay, well, in order to do that, or in order to get that wheelchair, you need to have this, this, and this, and this happen. and then your physician has to fill out all that paperwork, they send it over, right? And sometimes it gets rejected, and then you'll probably get that stuff back, and you'd say, okay, well now I have to prove that I have this so that the insurance company pays for that. So a difference with hospice care is it is like all included. And so when people join hospice in their last 6 months of life, then the hospice team comes over and just delivers them anything that they might need. And so that could be walkers, wheelchairs, beds, bedside commodes, which is like little toilets for people, oxygen tanks, medications. So they'll kind of run through all the meds that they're already on, and they'll say, you don't have to go to the pharmacy anymore, we will actually bring it to you at your house. And then the whole purpose is really so that people focus more on quality of life rather than maybe the quantity of life. And instead of trying to kind of go to the hospital or go to the clinics regularly, that they just say, I'm going to be at home and living my life. So maybe a good example that I have of that is I had a lady who had gallbladder cancer, and when she was told that, she said, I don't really want treatment. I'm not really sure about this whole chemo thing. People get sick from that and have nausea, and that's not going to be me. And so then she told the cancer doctor that, and the cancer doctor was like, that sounds fine. You can do hospice care, and then they will come and visit you. And so cancer, if you have cancer, then you're allowed to just qualify, especially if you choose not to get treated. So that was her choice. And the first time that I went to go see her on hospice, so we drove out to see her, she was not there because she was out at the mall. And so we were like, oh, okay, all right, we called her, well, we'll come back later when you feel like you're going to be home. And I think that was actually a really wonderful relationship for our team, because we got to see her for a good year and a half before she actually started to feel sick. So in the beginning, she was just like, look, I'm not going to do the chemo. I'm not going to do that. I have things to do. I'm going to go to the mall. I have my kids that I'm still going to be in a relationship with. I'm going to be spending time with these people. The only thing I need from you is that if I feel sick, I need you to give me stuff so that I don't feel sick, right? If I'm having pain in my belly, then I need you to give me something so that I don't have pain, so that I can go out because I have things to do. So, and I think that was actually a really, really neat thing for me to see on hospice care. So, because I feel like maybe the saddest thing for the palliative doctors on hospice care is when people choose it in the last couple days of life, right? Which I think is what most people think of with hospice care, is that they've told you, okay, well, we've went through all these different things and now nobody has anything. And maybe people are really, really sick. And then that's when they're going home. And then I think that's where a lot of these, maybe the myths of you get home and you only are just there for a couple of days. It's because those same people could have chosen that a long time before, where they would have had a team to kind of work with them, and they would have had a lot of things walked through. But instead, people kind of sometimes take it just in the last minute. And then I think people think, oh, well, hospice wasn't there very long, or hospice made people sicker, or maybe all the many things that I guess people have probably heard. I imagine people have heard not so kind things about sometimes hospice. So, and I think I see that when it is just when it's maybe I'm sent into a room and I spend time with people, but it's kind of when everybody else has thrown their hands up. And I think that's a little bit different from when people make their own choices about that and tell us what they want and what they value, and then we kind of coordinate things. Let's see. So this is just kind of showing, I think, that umbrella thing that I was talking about with palliative care versus hospice. So the palliative care is kind of included in the overall, and it's something that we can do a lot earlier, and then I think find more time to spend time with people and really get to know them, and then figure out what they value. One of the other things that I guess it does say on that slide, right, is that the one thing that hospice always provides is bereavement. And so that might not be things that people are thinking about, but I would say that that's actually a very pleasant and really nice thing. So I come with social workers, right, and hospices have social workers, and when someone signs up onto hospice, there's a lot of different things that happen after people finally do die, right? And so when they actually finally die, then hospice still isn't over. And so then what hospice can do is they're actually paid to still follow people's family and spouse and grandkids and everything, right? Friends, who are then allowed to have counseling and allowed to have bereavement services, and then they follow up a couple times, like at different intervals. So sometimes I think it's a 1 month, a 3 month, 6 month, and then year. And then if people continue wanting those services, then family members are allowed to continue to have that. And so that can be counseling, that can be just being able to kind of call and talk about it. The other thing that I think maybe that happens with hospice care that can be even though a sad thing, I think can be very helpful for families is I almost consistently get asked, like, well, what happens when someone does actually die, right? And so I feel like when somebody dies in a hospital, that's very medical. And so it's something that everybody kind of expects, right? So there's already a very clear process that happens. If somebody dies in a hospital, then they go down to a morgue, and family members get told, like, okay, well, this is where somebody could go, and when you hit a funeral home, then we'll send people over there. That, I think, is really straightforward, and I almost want to say that that's something that people expect. And so when they come into, almost when they're like sick in the last kind of couple moments, they're almost like, well, if I just get them to the hospital, then I'll get all those questions answered. And I will say that that doesn't happen when people end up dying at home. And so even though that is incredibly natural, and I think used to happen all the time in communities, right, we've kind of shifted that and we've put it into hospitals instead, or into facilities. So that could be nursing homes as well, right? And we've kind of expected that people there know what to do, and so they take care of it. And I will say that because hospice can go into houses, that really helps out families a lot, because I have had families that hadn't signed for hospice get really surprised and not know what to do when somebody's died at home naturally in their bed, right? Because then they're like, who do I call? Do I call the police? Do I call an ambulance? And then the ambulance has different rules about what they can do when they get there. Or do I call the funeral home, right? And so the people who are on hospice, I would say that's very easy. We normally tell them early on, all you do is you call us, right? And then we help take care of everything. So we can, there's a nurse that has been following people, generally coming over a couple times a week. And so they'll come out, they'll help family, and they'll say, this is how we transition, okay, we don't need to, sometimes, there's so many rules out there that I think are very difficult for people, but they can say, well, we don't need to go to a medical examiner, we can just get you to your funeral home, or we can take care of this, and we can do all this paperwork. Because maybe we didn't have that paperwork a long time ago, but I feel like we have a lot of paperwork around that now. So before, I think people would just sometimes die at home. But so maybe those are some of the other kind of maybe more morbid benefits of hospice, but I can say that I've had a lot of families that are very, very relieved when they only need to call one number, and they don't have to try to explain what's happening to the ambulance driver at 2 a.m, right, who doesn't know and needs to know where the paperwork is and has to figure out whether they have to bring the person into the hospital or even whether they have to start CPR, which can be a very difficult thing when somebody has clearly passed. But there's rules and there's laws in Texas, so they have to comply with those. But when hospices are involved, it's a much easier process, because then they'll say, oh, you're on hospice. Okay, call the hospice. The hospice will say, okay, well, we've got this paperwork, so you don't need to do that, and you could just wait and we'll get there. So, and I feel like that's a big relief when families finally have some of that. So,
Question?
yes, go ahead.
You mentioned bereavement care on the previous slide. So, do you ever recommend, like in our church, we have a ministry called Grief Share.
We do.
Do you ever recommend people to possibly check out Grief Share?
Yes, we do. And so our social workers, I would say that is one of the things that they have as kind of a list of where people have grief shares. And that's something that maybe we even recommend in the hospital even before. So, because there are plenty of times that people can go to grief share and they don't necessarily have had to, I mean, the whole process of grief, right, doesn't necessarily start at death, right? And so people can be grieving a long time before, and I know, and are still like have access to things, right? You can grieve the fact that you have been diagnosed or the future loss of something, right? There's something called anticipatory grieving. And so, yes, we do. But no, that's an excellent question. So I think sometimes it's not just that the hospice has bereavement stuff, right? I would say that that's something that's maybe included in each one of the hospices. And sometimes they tap into what other people have. So they may say like, okay, well, you know, this is the list of the grief shares in the area, or it doesn't always have to be grief share. It could be like the Warm Place in Fort Worth, which is for kids, right? And so we could say like, okay, well, you know, that the hospice can refer people over there, right? When it's, I guess, maybe it's more often and more common, maybe not on hospice, that we kind of access grief share and that we access other facilities. And that is because before hospice, so if it's in a palliative clinic, or maybe it's palliative medicine hospital, then we might give a list of different places that people can go so that they can have access a little bit earlier for some of that, and they don't have to wait until kind of the end. So.
Is the palliative care covered by Medicare?
Oh, yes.
It says hospice is, but it doesn't mention.
Okay, no, that's fair. Good question. So I would say I can start with hospice is covered, right, by Medicare, and that is Medicare Part A. So A takes care of hospital and hospice. And so anybody over the age of 65 who has, I think, a quarter of work, right, is able to get Medicare and is a U.S. citizen. And if they're younger, then if they had some sort of disability, I guess, after 62, and that can also be like end-stage renal disease, so if somebody's on dialysis, then they can get Medicare. And then they could easily get hospice. So hospice is covered by Medicare, and that's probably the easiest thing for any hospice is Medicare covers it. Some of the other insurance companies don't necessarily cover hospice. So sometimes they do, sometimes they don't. Palliative care is kind of a thing, is before. And I will say that is kind of maybe more experimental right now, but I feel like there are big programs. And I know Dr. Capper was supposed to speak tonight, right? And he had actually started maybe one of our large outpatient palliative care kind of arms of a hospice. So he's got a big hospice called Community, and that has hospices, and then he has this other little part of it, or actually a pretty big part, I think now, that does palliative care as an outpatient. And to my knowledge, they're getting it covered by Medicare because it's kind of similar to home health and maybe similar to an outpatient visiting physician. So we don't always do this, but I think there are physicians that do home visits still, right? And so those companies do exist and they bill Medicare, and Medicare does cover visiting physicians. And so I believe, and I can't entirely speak to all of that because I don't run one of those companies, but my understanding is that they have it covered because they have worked that out with Medicare where they're kind of doing outpatient physician going to visit and providing home health services. So it's a good question, though. I think that it probably depends on what you have. Like, I think I imagine Medicare probably covers it before other things. But if you had like Blue Cross or Cigna or one of the other insurances, I'm not entirely sure.
Is it considered, palliative, is it considered a specialist? So you'd have to pay a separate copay for a specialist? Like if you're on Humana or something like that has a copay for a specialist?
So if it's in the palliative care, like in a hospital, then I feel like that would, even with Humana, I guess Humana's managed Medicare, right? So then that would be covered. If it was an outpatient clinic, I guess if you had to pay for a cancer specialist as a separate, then you would probably pay for the palliative as a separate. And if it's the outpatient palliative, then I know, right? It's a very, very confusing thing. I think if it's outpatient palliative, it would probably be, however home health was covered. So
Medicare thing.
I believe so. Yeah, I mean, I don't run that, but they do. Yeah, I don't know what the copays or, I think that stuff changes based on who's managing the Medicare, right? And then those are complicated questions. That's a good question, though. So I don't know maybe the ins and outs of when it's paid. I think that's actually one of the reasons why when we talk to people and we say sometimes that transition to hospice care becomes a lot easier, because as soon as people choose to move out of the medical insurance world and say they're going to hospice, hospice is just a single fee that is paid to the hospice organization, and they are responsible for all care after that. And so then there's no more paperwork of, like, nobody's charging you something extra, because it's all just the hospice. They have to provide the services, and so they have to figure out how to do that for you. And so I would say that's actually a much easier version when that happens. So, do you have a question?
No, I got a comment.
Yeah.
On the palliative side is, I found that they've helped with symptoms.
Yes.
For instance, my wife couldn't swallow real well. So they said, we need to get you over to speech therapy.
Right.
And then sure enough, the little gal says, well, when she takes that straw in her mouth, she gets one drink, not four.
Mm-hmm.
Kind of thing, because she was choking. The other question I had, though, was, at least it's been told to me that, as hospice progresses, there's different levels of hospice. And when it gets to that terminal point, that they will typically, in-home or in a facility, when it gets to that point of close to death, that they will be there more than likely on a 24-hour basis. Is that correct?
Yeah, that is correct. So the places that hospice it can take place, right, at home for people, can take place in nursing homes, and then inpatient hospice, which is something similar to maybe what you're referencing. And so I would say that when hospice starts, like for instance, the lady that I said, okay, I went there and she was out at the mall, right? So they're required to see her still. We were still required to see her at least once or twice a week. And she clearly didn't need that, right? So we were still seeing her that frequently, but then as she got sicker with time, then the frequency goes up. And so with hospice, it can start at 2 times a week, but at the very, very end, it could be that people are coming every day. It can be that people do what we call, I guess a 24-hour, and I think they're only allowed to do it for 2 days generally, straight. But they can do in-house, right at the bedside care, where maybe the bed is in, somewhere in the house, and they've come in and they've got a nurse sitting there actually helping with medication administration and being with family. And that can be a 24/7 thing. Yeah, or not 7 thing, sorry, 2 days thing. The other option is that people can move to these inpatient facilities. So an inpatient hospice, there's a couple of them in downtown Fort Worth, but they kind of look like maybe a really nice version of a nursing home. So I would say, they don't have all of like the hospital staff, and it's not big buildings, they're smaller. They don't have like, huge wings. They may only have maybe about 7 people generally there, but everybody would get a private room. There's normally space for family members to stay and sleep. And they normally have, something like a little library or a kid play area, a place where people can eat. And then people are allowed to stay there, and you're allowed to stay there for the last 7 days of life. What really qualifies people for getting to go to an inpatient facility is that they need to go. So if you're just at home in the bed and you seem like you're very comfortable, right? And maybe they're sleeping and nobody is having to do big things, right? But just kind of occasionally give a little bit of medication or give a little bit of nausea medication or something like that, then a lot of those people will stay home. But the reasons that they would go to an inpatient facility is they really need like full-time nursing care, right? And so it would be like, okay, well, somebody's maybe got wounds or something that somebody needs to help with, or the pain medication's not working anymore, and so they need a different way of getting that. So they might need patches, or they need to put an IV in, right? And that is the kind of thing that people would go to an inpatient facility for. But yeah, hospice can ramp up. So they can start at just not have, just like once or twice a week, and they can go all the way to kind of a step down from a hospital. So, or if people say, no, I want to be at home when this happens, then they can actually send somebody there, and they can be there overnight in the house. That reminds me that there's another kind of portion of hospice, another service that they provide that's part of that hospice is that they provide something called respite care, which is where it is very difficult, and I'm sure some of you maybe have experienced this, but it's difficult to be a caretaker 24/7. And so one of the things that hospice can do is people can say, I, as the caretaker, know that this Thursday I have to go and do my shopping, right? But I don't want to leave my spouse at home on hospice. And so then they will send a nurse over or a CNA, maybe a nurse assistant, to say, we're going to stay here in the house and take care of that person while you go and you do all the stuff that you have to do, and then you come back and then you kind of swap off. And so it's just a lot more support, I think, and maybe a little bit different from just standard medical support, because I think it's supposed to be very inclusive, where it's kind of recognizing that when people are sick or terminally ill, that there's a lot of other things going on, and that, that there's family involved, that there's a spiritual component to it, right? That there may be financial components to it, that there's emotional components to it, that that there's just so much more than just somebody being sick. And so I think the hospice teams are there for all of that, to kind of walk people through that stuff. Did that answer that question? I think so.
But they will
And then,
cover 5 days in a nursing facility also, per month.
yeah, that's probably true. I think that, yeah, for nursing homes, each hospice has its own kind of contract with nursing homes, because you can live in a nursing home and still have hospice, and it would be like 2 teams, right? So it would be like the nursing home team and then a second set of eyes where the hospice team comes in every couple of days and say, okay, we're also checking on this person. I know I've actually recommended that for some times, because I'm sure that maybe people have had experience with nursing homes, but they're not always the nicest places for people. And sometimes the difficult part is communication. And so sometimes family members will come in and it's like, well, the doctor only has to come here once a month, so they're not here today, right? Or, the nurse that had said that and called you is no longer on shift or something like this, right? And there's just a lot of communication kind of turnover. And one of the nice things about hospice being there at the same time is that you still once again just have the one line, so you can say, okay, well, I'm calling so-and-so at hospice who knows who knows this patient and has been there regularly, and then I can ask that question, and even if they don't know, they kind of have access to walk into the nursing home and kind of get those answers and bring them back to you. So, yeah. Oh, yeah.
If you're on hospice and some reason you need to go to the hospital, does that keep the insurance from paying for that hospital stay?
So actually what's supposed to happen is that the hospice normally what happens, because the hospice would have to pay for the hospital, right? Because it's that umbrella that if Medicare pays hospice, then hospice does all care. And so if somebody needed, let's say, like, it could be something simple, right? So let's say they're on hospice and they have pneumonia that they would like treated. Sometimes the hospice can just say, well, let me give you those antibiotics, right? Other times patients might be like, well, I'm sick enough that I want to go into a hospital. And so then if that's the case, then hospice would owe the money for the hospital. So what happens, and just like logistically, is that they normally say, if you're going to go in, then you have to end hospice, right? And so then you revoke hospice. And there's some paperwork that's involved in that. And then people go to the hospital, and then Medicare pays for the hospital. And then they decide to come back to the hospice afterwards.
My mom was
Yeah.
on hospice and she fell and
Right.
ambulance said that she needed to be going in
Yeah.
and checked up.
Yeah.
And then United Healthcare didn't want to pay for her hospital stay.
Yeah, I would say that normally, I guess, the hospice needed to do a revoke. Yeah. So there's paperwork where they revoke the hospice and sign that.
Don't know that.
That's true. Yeah, I guess I would say that I think that that's the hospice's responsibility. So I know I work with Serenity, and we do have patients that go in for various things. So maybe somebody's like, well, I'm going in for another blood transfusion, right? And so then we would have to be like, well, you have to revoke. And then you get your transfusion, and then if it's, the next day, you can come back, and then, you can set that up again. But yeah, you're right. Otherwise, Medicare wants to make sure that either the hospice pays for it or somebody pays for it. But yeah, you are supposed to carve that out separately. Yeah.
$11,000 invoice that got them fully paid
Okay.
for a CT scan.
She fell.
When my wife
She was on
fell.
hospice.
From,
She fell.
oh, okay.
And she could be bleeding inside.
And I took her right to the emergency room down Willow Park.
And then United Healthcare didn't want to pay.
And I suspect that's because there was revocation paperwork that the hospice filed. So,
I did have to call hospice.
yeah.
I did call hospice. And they said, well, we'll send a nurse. And of course, you have to advocate.
Right.
You have to be the advocate for your person.
Right.
She was in
And they
the
said, well, the nurse will come somewhere from Dallas, Fort Worth, and they'll be there in an hour and a half. And I said, I can be at the clinic or the hospital in 30 minutes.
Sure.
And again, it becomes a live recording. Well, is that what you're going to do, sir? Based upon your timeline, sir, that's exactly what I'm going to do.
Yeah.
I hope you're recording.
But I imagine that hospice just revoked temporarily. So, I mean, it's not a temporary, they have to do revocation paperwork. And so,
The paperwork I got came from Blue Cross Blue Shield.
sure. No, but I'm saying that so what should have happened maybe is that the Blue Cross Blue Shield sent the bill to the hospice, who then probably said, we talked to them and they revoked hospice, right? And so that's actually what's supposed to happen, is that they probably should have, the hospice that was working with your mom needed to also say, I think you need to revoke, right? And then you come back on later. So otherwise, I think then it's a disagreement of who's paying for what. Yeah. I can't speak entirely to how terrible the insurance industry is, even Medicare. So, right, that's hard. It's fair, yeah. Oh, let's see. I feel like we've talked about some of this, haven't we? Ask sooner. Maybe we've talked about some of that too. Ooh, those are tiny words. Even my bifocals don't get that. So maybe we've spoken maybe about that first one, but some of the other questions that I think maybe people have, that it's a good thing to ask palliative providers, right? Or even in a hospital, if you've come in and you've gotten the diagnosis of something that might be a more permanent disease, then I think some of the questions that you can ask that I think are helpful, and if you're not getting answers, then kind of take that next step. But I would say that one of them would be something like, what is the natural progression of this disease? Like, what actually happens? Okay, so you've told me that I have cirrhosis, or I've got a lung problem, I've got COPD, or I have this cancer. Like, what does that actually look like? And tell me what that looks like over the next 3 months, 6 months, 5 years, right? And I think when people don't get answers from their docs, because I think sometimes that does happen, right? That even physicians don't necessarily want to answer those questions, then I think that's actually where palliative doctors are really good at. And so one of the things that I think is helpful at that time, and I've had people who have met us maybe in other circumstances, or even, I guess I would say, healthcare workers where their families have come in and they say, like, you're not getting answers from that doctor, so I want you to ask for the palliative team to come by. And I think that's something that we focus on communications and goals and getting answers for people and trying to align. And so that is something that people can ask for, and they can say, well, I would like the palliative team to come by, and then maybe explain to me, what does this look like, right? So you've told me I've gotten this disease, but what does that look like over the period of my life? And I really have some real questions that I need answers to. And then that's actually the palliative job, right, is to sit there and say, okay, well, I can tell you that when somebody gets diagnosed with, I don't know, like a pancreatic cancer, then this is what it looks like in the next couple of years, right? And then we kind of walk through those things. So, but I do think that that's a very helpful thing, and sometimes when people aren't getting answers from docs, then it's a good way around that, where you can say, well, I'll have maybe a palliative doc come in and ask that, and I want to ask those same questions, and then they have the job of going to talk to all the different doctors and kind of act like maybe a medical translator, and come back and sit down with you and say, this is what all the other medical teams have told us, and this is what our expectations are, and then you have kind of more information that I think you can work with. That next one is about advanced care planning, which I don't know if you all have done. Did you do that in the seminar so far? So some of that maybe is similar to maybe the medical side of wills and trusts and stuff like that. So there's advanced care planning paperwork, or advanced directive paperworks, where people will say, if I can't make decisions, then this is who's going to make decisions, right? And so choosing either a family member or a friend, running down that and kind of saying, if they are not here or they can't answer that, then you go to the next person. And those are all legal documents that get signed. Oh, okay, good deal. And so that's stuff that I think palliative care teams help with too. So for our patients at JPS who don't really generally get to go off to a lawyer to have them fill out that paperwork, our social workers do that. And so they'll come in and people will be like, okay, well, I don't, has anybody ever talked to you about what you'd want if you needed a feeding tube, or if you were stuck on a breathing machine for a really long time, or or things like, do you want CPR, right? Do you actually want people to resuscitate you with compressions? And when would you want them to stop? Or what? There's so much that can go into an advance directive, where people can kind of write in things, and sometimes incredibly specific. So, I mean, I've had people where they're like, well, you get to do exactly 2 rounds or 45 minutes, and then after that, you have to stop. And I mean, there's just or you can keep me exactly 3 days on the machine, and you're like, oh gosh, sometimes that's tying doctors' hands. So maybe I would advocate for a little bit looser stuff, but I will tell you that that's all stuff that can be done under the umbrella of palliative care, and so people do that in hospitals too. So they may come in and they've never really thought about what they'd want done, and then social workers, palliative social workers, can kind of sit there and walk through all of that with them. Other questions that I guess I would encourage people to ask is, what they truly value in their life. So I feel like, the quick answer for people a lot of times is just that they want to be cured, or they just, want more time. But I think it's a lot nicer for palliative teams when people kind of really say, these are the specific things that I really value, or that I really want, or like, I mean, I've had a guy who was like, I don't want, he was like, I don't want to lose the ability to barbecue outside. So whatever things that they offer me, I need you as the doctor to come in and hear what options they gave me and say, does that stop me from being able to go outside anymore and use my smoker? Because if it does, then I would like an alternative option. And then I think palliative docs are able to kind of say, okay, well, it doesn't have to be an all or none thing, but maybe we can find something in between. And we kind of talked with the other physicians about that. And then, let's see, the next question on there is about legacy. And so, how do I see my legacy? And that is something that I think we get to ask patients and spend time with them, and sometimes even help people who have maybe even not talked about certain things or thought about certain things to be able to kind of walk through some of that. And so we've got specific paperwork called legacy documents where people can write short stories essentially about their lives, or answer questions, or write letters to, some of that is hard even for palliative docs, right? But I write letters to their grandkids for when they graduate, or different things like that. So really cool things, I think, or make videos. And so we do a lot of that stuff. I don't do that stuff as often, because you see that it's a little bit hard for me with my kids, right? And then the last thing is that I think palliative docs and teams really focus on dignity for people, and what that means, because I think that in the medical system sometimes people get like medicalized, right? Where you're just like, you get this, and then you get that, and then you get this, and then people kind of don't realize that there's certain things that maybe you wouldn't have said yes to, or you didn't know what that meant, and you wish that you had known what that meant. And I think that's stuff that palliative teams are really good at, is kind of walking through what that means, because maybe if it's the first time that, that a patient has never even heard of a tracheostomy or something like that, or colostomy, or different wounds or something like that, right? I have seen an awful lot of patients go through it, and I've had them tell me about, about how some certain things in their life have changed with it. And so then we kind of walk through how that affects other people, and how they can kind of choose what their limitations are, and that it doesn't have to be just that the doctors kind of forget and just say this next thing, this next thing, this next thing. So, all right.
4 more minutes, anybody else? there time for any other questions?
Yeah, I feel like I think I'm at questions, right? Ooh, look.
Start making the transition to our next session. Anybody have a
So
question?
you're saying if you have, somebody needed a feeding tube, you needed a medical power attorney to do it, or
No.
just,
No.
Ken can answer that question?
Yeah, absolutely. If people have a medical power of attorney, then that's who we would go to as providers. If they don't have one, then Texas has a specific law that says who we go to. So we go to spouse first, then we go to adult children, then we go to parents that are still alive, and then we go to any other relatives. And they're all grouped together, so it could be like your niece or something. Like, that you haven't seen for 20 years. So sometimes we advocate for medical power of attorneys so that you don't have people come out of the woodwork to decide for you.
Any other questions, anyone?
No?
Anybody?
Yeah.
All right.
Hopefully not too depressing of a topic. I'm like, I am talking about death. Yes. So.
Mike, you and your family attend church in
Church of the Crossing, yeah, down in Alito.
Toledo, right? How does your faith play into what you do?
Oh, sure. Yeah, that's an excellent question. So I think as a doc, I would say that it is, so I trained in California and in Boston, and I would say that those were very, maybe, religious places that I was not allowed to really do things, right? And so, it didn't mean that I didn't pray with patients. I mean, I feel like I prayed in Boston with my first patient who had cancer when I was a third-year med student. And in Ventura in California, I also prayed with patients. But I think it was definitely frowned upon. So here, I think one of the beautiful things about palliative care is that I have patients who maybe aren't religious, or, sometimes I'll ask questions, and that's actually part of my initial evaluation, is finding out maybe what religion somebody is, or what faith background they are, or even if they have any faith background. And I think maybe one of the special things that God has kind of helped me with and given me in a really nice thing in palliative care is that because of the nature of terminal diseases, or even just learning that you're very sick, I think that people all of a sudden, even people who haven't thought about it for a long time, start thinking, right? And so I have patients where, I've asked, like, do you have a faith background, or is there, somebody that you can turn to, or is there any spirituality kind of, and I've had those patients turn back to me and say, no, I've not really thought about that, but I am thinking about it now, right? And I feel like I'm becoming more religious every day, right? And I think it's because that's that existential moment of, like, people finally questioning the meaning, right? Yeah, and so I have a chaplain, which is wonderful. I have 2 chaplains that sit with me, and sometimes we'll all be sitting and praying with families, and that is something that is really cool as a palliative doc, because I'd say that, when I walk into an ICU, it is very uncommon for the ICU attending to stop what they're doing and pray with a family, right? But I would say that when I'm in an ICU, that frequently that is expected, right? That as soon as we've talked about somebody's faith and they're like, this is something really important, and I get to say, hey, well, I'm a Christian as well, then, we all get to pray about things. We all get to pray for God's healing. We all get to pray that, that God will help in this journey, because I think sometimes, everybody wants the journey to continue here, but sometimes it doesn't. Sometimes you get to go to heaven, right? And so I think, but that is a beautiful, beautiful part of palliative care that I feel like I get to pray with patients all the time. So, and people actually want me to, which is really nice. Yeah. So.
Thanks for sharing that.
Yeah, absolutely.
Anyone else?
All right.